I welcome you all to the awareness program organized by SHUHS on the occasion of International Disability Day. First of all, I would like to thank Srimanto Sankardev University of Health Sciences for organizing such a nice program. To start with, we go back a little into the history. The annual observation of this day was started in 1992 by the UN General Assembly resolution with the aim to promote the rights and well-being of persons with disability in all spheres of society and development, and to increase the awareness of the situation of persons with disability in every aspect of political, social, economic, and cultural life. This year, with the prevailing COVID-19 situation, UNESCO has marked this day with a week-long program from 25th November to 3rd of December, that is today. The theme of the program was Building Back Better towards an inclusive, accessible, and sustainable post-COVID-19 world by, for, and with the persons with disability. With this, I would like to welcome our chief guest, Professor A.C. Bashir sir, the principal of GMCH, all our guest speakers, and our audience. Due to unavoidable last-minute hassle, our Honorable Vice Chancellor, Professor Deepika Deka ma'am, will not be able to join us, and she has expressed her deep regret for the same. So now I would like to request our chief guest, our principal GMCH, Professor A.C. Bashir sir, to address the gathering. Sir. सर अपना म्यूट है ऐसे सर म्यूट है ऐसे सर.
Yeah. Good evening, everyone, and welcome to all of you to this special session for this World Disability Day. And unfortunately, the PC madam I met just now, few minutes back, that due to her illness, she is not attending. And thank you, Vikas, for introducing this topic. And the importance of this disability care, it is not a single day care. It should be a sustainable in our health sector. But only to bring back to the forefront and to making the community understanding the issues of the disabilities. And when people will understand the issues of disabilities, they will mobilize resources. They will try to keep the rights, dignity of the disabled person in the society. So with these objectives, every year, 3rd December, as Vikas has already mentioned, that week-long program, but 3rd December is a Disability Day, are being observed by the UN agency since 1992. And rightly saying that this year, the most suffered community is the disabled community during this COVID-19 pandemic. And since the beginning of the countrywide lockdown, from not countrywide, it is the whole worldwide lockdown. And since March 2020, then the sufferings of the people are much. We have seen that how the normal people suffered, and again the segregation of the disabled people from the community and from their family during this lockdown and during the COVID period. Definitely it is a troublesome period. And this year, due to this COVID pandemic, the theme is building back better. That means if we could do better than before, building back better towards an inclusive disability, accessible and sustainable post-COVID world. We should not segregate the disabled community, this handicapped community. So how to build up that better facilities and everyone to be inclusive, whether they are in community, they are in hospital, they are in different settings. So how to give the appropriate care due for them, the primary care, including rehabilitation, how to give them in their doorstep, including all the disabled person. And it is not only the physical access, it is not the geographical access, it is a services. Because physical access is a different thing, geographical access is a different thing, but the accessible service to these disabled people is the most important and sustainable things we should make to the community, in the community. And this is the theme of this year, that due to post-COVID, whatever we are building, whatever we are restructuring, and all of you know that COVID is a big leveler this year. And we have seen from the near that COVID has brought down everyone to the same level. And considering this opportunity of the COVID and the restructuring of the health sector, restructuring of the social, definitely the COVID has given the opportunity for us to remove the attitudinal, institutional and barriers which we may build a better facility for the disabled person. Particularly, if it matters for the screening, it matters for the care, it is matters for the whatever the service provision in the community, in the other service, rehabilitation service, the service should reach them. And particularly, giving from the example from my own hospital, Guwahati Medical College, yes, we have a big screening center. We shifted to the big screening center, but still we have the separate counter for these people, elderly people, disabled people, specially able people, so that these people can be segregated for the better care, timely care, and this compassionate services to them through our workers. We have got dedicated people for that, so that these people are being received, given the testing facilities, and they are dispersed with the shortest possible time to make them comfortable and to leave the area comfortably. And coming to this facility, coming to the facilities, whatever these are the facilities we are creating for the COVID this year, that each and every facility in the districts or in the state or in a medical college, whatever the hospitals we are doing, we are taking care of that. It should be disabled friendly atmosphere. So that, and if someone has seen, particularly our hospital, the super specialty hospital, which is a COVID specialty hospital, then every floor we have got that is the disabled friendly planning, and every floor has got a different toilet for the disabled people, so that it is accessible in front, it is the service can be utilized by the disabled people without much difficulty, and it is not in the ground floor of the OPD area. If we go to any floor, that this planning is in such a way that the disabled people can access the toilet by any difficulty with the signages as well as the accessibility. So this is the necessity of the time, that if we build something with building back better, whatever the service we plan post-COVID, this should be disabled friendly, this should be having these all facilities in mind, whatever it is isolation ward, whatever it is a family settings, whatever is a community settings, it should be done in such a way so that we can serve them better. And particularly, we have seen that even in our ambulance services, particularly for the post-COVID or COVID, whatever we have seen, because if you see that since the March, we're using these 108 services, all the drivers, all the caretakers of the ambulance are being trained specially how to take the how to take the responsibility of the, if some disabled persons are being called for, they are calling for their help, and how we can do the better service for them. And at the end, it is not a day we remember the disabled people. In our health sector, it should be an integral part, because if we go for the universal health coverage, then we will see, then in case of universal health coverage, that the one of the component of the primary care is the rehabilitation. This rehabilitation may be social rehabilitation, this may be the occupational rehabilitation, this may be the physiotherapy, whatever the requirement of the this situation of the disability arises, we should be friendly to them, it should be accessible to them, so that at the end they are equal. Because except if we are not sensitive to them, if we are not responsive to them, definitely that they will be getting the segregation in the community, in the society. So at the end, again, it is not a one-day job. It is a sustainable job for us. I have seen the many of the stakeholders today, particularly the orthopedics department, is one of the most important stakeholder for the disabled people in the health sector. Then the ENT, they are another stakeholder for this disability in this community. Then whatever the form of the disabilities for a person, we should come forward. We should include all types of disability in our health sector, how to rehabilitate with medical rehabilitation, surgical rehabilitation, whatever this social rehabilitation and occupational rehabilitation to them, so that at the end we can make a better future for them. And with these few words, I thank you, all of you, for inviting me for this noble occasion, this gathering, August gathering of this eminent people of the orthopedics, whatever we have seen in the screen, and their contribution as a Rotarian, as a Lions, or different platform. They are rendering the services to the mankind of the disabled people in different form, in providing them the physical rehabilitation, then orthopedics rehabilitation, whatever the informs. So thank you once again to all of you and the organizer for this giving me this opportunity. Thank you, sir.
Thank you, sir. Thank you, sir, for such a nice introduction. And now we have a series of lectures, very nice lecture by our guest speakers. We have time to, if anyone has any queries in between, they can put it in the chat section. With this, I'd like to first invite our very own Professor Anil Mohanto, sir, retired professor and HOD of Department of Orthopaedics, Guwahati Medical College, for his lecture on an approach to rehabilitation of the physically disabled in the society. Professor Mohanto, sir.
Good evening, everybody. Am I audible? Hello?
Yes, sir, you are audible, sir.
Oh, thank you very much. Good evening, everybody. It's my great honor to be a part of this day, World Disabled Day celebrations. And I am grateful to the organizers for giving me this opportunity for being part of here and speak on a particular topic. I can share the presentation now. Screen share is allowed. Hello.
Yes, sir, you can share.
Ronnie. Hey, present.
Because তুমি স্ক্রিন শেয়ার নকৰিবা সারে কৰিব
না মই কৰা নাই
Vikas, sorry. Vikas,
Yes, sir. Yes, sir.
hello. I have sent your presentation there. Now from there, your present. I have not been able to put it there. I don't know.
Sorry.
The PowerPoint or nothing more.
Okay, sir. It's uploaded, sir.
Okay. Okay. Let me start. I wanted to speak something about an approach to the rehabilitation of the physically disabled in the society. As I'm grateful, the Professor Bashir sir has delineated the various aspects of physical disables, and in he has highly spoken about one specialty, that's the orthopedics surgeons are involved. And we are concerned about the physical disability part of it. But coming to next slide, please. Talking about next slide, please. Next. World Disability Day, as Professor Bashir has already mentioned, is Vikas has mentioned it, that it is a UNESCO-sponsored program, WHO and World Body UN. Every year he has been celebrated, and this year also, nothing exceptions. But thing is that one thing to be remembered here, to me, that this day was first celebrated in 1982. Then 82 to 92 was a decade of this physically disabled. And 92, it was named as International Day of the Disabled Person. But since 2007, the name of this day has been changed to International Day of the Persons with Disabilities. It reminds me of a very fundamental things in clinical medicines, that we used to say the usual tendency of a physician is to refer to a patient as a tuberculosis patient. This is a osteomyelitis patient. What is bed number 7? It is like a CA breast. What is that osteomyelitis of patients? But no, there is no tuberculosis patient. There is no osteomyelitis patient. There is a person with osteomyelitis. There is a person with tuberculosis. So it is the man who is having something. Don't brand him as the peasant sort of thing. So that's the philosophy in renaming this day from International Day of the Disabled to the International Day of the Person with Disabilities. These are the persons, absolutely normal person like you and me, but they have got something there, which, and I'm coming to that. Next slide, please. Next. So this particular year, this is 2020, as Basasa has already indicated. This is the particular theme has been given. Every year it is given. And this year is very, very pertinent to remember. They have said that all disabilities are not visible. When you talk about disabilities, there are disabilities of the parts, disabilities of senses, disabilities of functions. But all disabilities are not visible. So the stress on this particular year is that building back better. When you say building back better, you admit implicitly that so far what has been done is not been up to the mark. We've been trying, but not up to the mark. So this condition in 2020 is an godsend opportunity in one aspect. As already mentioned, that COVID is a great leveler. It has exposed many things in the healthcare system, in administrative system, in the societal system. So after this devastation of the human race has so far endured, If you are going back to build something back, you build something better. And how? Towards the disability inclusive, accessible, and sustainable post-COVID-19 world. So, when you are rebuilding your society, when you are rebuilding the health delivery system, you have to keep in mind the, the conditions, the desires, the necessities of the disabled person. Next slide, please. Next. Why World Disability Day is observed? For any observation is a significance. Birthday is observed to remind ourselves how beautiful life is. So this day is observed to promote the understanding of the disability issues, so that the society is reminded that there are issues associated with the people with disability, and they are concerned about. The first thing I will put is the dignity. The human dignity is of the utmost importance. You have to respect him as a man, as a human being. And everybody, as other people in the society they have got rights. We have to keep on the rights of these people. So when you learn to respect the dignity and the rights of the people affected with disabilities, then we can proceed to arrange for the well-being of the person with disabilities. So very basis of addressing the issues of the disabled, the people with disability, is that they have a respect, dignity of the man, and be careful about his rights. So that's should be the foundation stone on which the rest of the philosophy of helping out these people can be done. Next slide, please. So by definition, who is disabled? WHO resolution is of disabled person is that any restrictions or lack of ability to perform an activity in the manner or within the range of considered normal for the human being, resulting for impairment is termed disability. Any impairment. This might be the impairment is caused by physical restriction, absence of the part, or anything, or perception of that thing. So this is a wide spectrum of conditions can lead to disabled conditions. Next slide, please. So example, as already mentioned by our principal, that one is orthopedics because it affects the locomotor system. So it's very obvious, but there are hidden things also. The vision impairment, hearing impairment, mental faculties, intellectual disabilities, all these things. But being an orthopedic surgeon, my concern is of the physical disability part. So physical disability part, so I'll be stretching on more on that part. Thank you. Next. So how big is the problem? Roughly it is said that 15% of the world population has some sort of a disabilities, but the actual number, difficult to say. In Indian context, even it is more difficult because there is a paucity of data. Even the data concerned turned out by the National Sample Survey Census, there's about 2% of the population or all these things, and there are regional variation, there's urban-rural divide, all these things. So practically speaking, it is very difficult to get exact number of disabled persons in this country, but there are a lot, definitely. So by going by world standard, might be, it will be about, if not 15. In US, there recently there was a agitation sort of thing where people claim that 20% of the population are disabled, so some sort of a special consideration to be taken on all this politically. So roughly you can say yes, 15% can be there. So it is a big number, absolutely big number in a country of more than 1 billion population in this country. Next slide, please. So problem is that in actual getting the correct position of the disabled person, which is termed as the iceberg phenomenon of disease, because the surveys doesn't bring out the exact number. Because why? Two things. It is the attitude of the surveyor, and secondly, mild and moderate cases actually escape from the survey network. So one side, and another problem with cultural is that nobody likes to come and declare himself to be unless there is some incentive sort of thing to say because of social stigma and other things. So cultural perceptionalities which are there, then all this accessibility, all these things. So we are not going to talk about the exact number and these things. Next slide, please. So talking about physical disabilities, causes of physical disabilities can be many. As an obvious thing, the loss of a limb, and loss of a limb was visually thought to be because of the infective lesion, amputations, or injury leading to infection and amputation, that sort of thing, congenital, and all these things. So basically, there are the communicable diseases that are infection and other things, and non-communicable, congenital, and other things. But more importantly, lifestyle diseases are leading to this. The causes of amputation and orthopedics are known in a developing country. It was the infection, trauma, and all these things. No, now it is taken over by the diabetes and thromboembolic phenomenon because of this the lifestyle diseases. So the dynamics of the causes of the physical loss of limbs and physical disabilities that has resulted is changing over the age, over the time, and more of a developing country like that. This is changing from a communicable diseases to non-communicable diseases. Even trauma, yes, it has contributed along with the, we always talk about vehicular accidents and all these things. So these causes are different and causes are variable in all these things. Next slide, please. So when you talk about that, so these disabled people, physically disabled people, has to be brought back to the mainstream and make a useful citizen contributing to the society, because that was the philosophy I have mentioned. I will come back to that again. So what do you mean by rehabilitation? Rehabilitation is a set of measures that assist the individuals who experience or likely to experience a disability to achieve and maintain optimal function in interaction with the environment. The operative word here is the environment. Environment can be a physical environment, emotional environment, social environment, and the environment internally to himself. That's why in the very beginning I said the first cornerstone of the rehabilitation philosophy has to be restoring the dignity of the person back. That will set a motion a lot of things there. So the whole idea of rehabilitation is that make the man, that individual, fit to live to this environment around him and live a life. Next slide, please. That will include, this whole thing will include one attitudinal connection. When we talk about disabilities, usually we try to express very crudely about physically handicapped, physically disabled person or physically handicapped people. But no, as we have said on the Dibanger, the specially able people. So they are the people with disability. They are not disabled people. They are people with disability. So they are specially able, or rather disability we don't call it, they are specially able. So this is the whole approach is that yes, he is an individual with desires and liking, disliking, and their way to live a life. That should be the thing of a things. The whole attitude of the rehabilitation will depend on that. Everybody has got aspiration to live a life, but he has got something lacking in it. That's the disability. So our aim of all this approach to him should be helping him out to live the life by assisting, by ameliorating the deficiency, that drawback that he has got. But he is a full individual having all the rights of living the life here. Next slide, please. Next slide. This is a picture, those who are aware will know, the Mayuri. See, and if we look, she's dancing. She's the normal person sort of. But you look kindly, please press again, because that will show that she is actually an amputee. Next. The leg, on the right leg is an amputated leg, and on amputee, prosthesis, below knee prosthesis, she is dancing Bharatanatyam. She is accomplished dancer. And this you will press it again, it will come, I think. Hello, next. Yeah, if you could look at intently, I think you will scan it. This is the Jaipur food. This is a classic case, an iconic picture of a rehabilitation success in India, with a Biloni amputee, with a Jaipur foot dancing as accomplished dancer, having won his accomplishment all over the country. Next slide, please. So let us think that when we are going to think about rehabilitation, we have to think that rehabilitation is aimed at enabling that person to participate in education, to develop his personalities, make him skilled so that he can participate in the labor market, to earn his livelihood, live a life with dignity, and most importantly, make him participate in the civic life. He has to be part of a functional member of the society. He cannot be segregated out. He cannot be kept as a special specimen sort of thing in the society. But the whole approach has to be to enable, empower that person to be a functional element, functional unit of the society. But remember, this is always voluntary. That means there has to be desire from inside the person, motivation from the person to come forward and participate in it. You cannot force it. Like in surgeon, we always that sometimes we have to force the treatment into the patient, because in effects you have to notify you. But even in COVID, even if you are not willing to get him tested, you have got something for the benefit of for the safety of your neighbors, for your family. You have to get it tested and get it isolated. This is not rehabilitation philosophy. It is voluntary. Has to be inner motivated. Then only we can be successful in any attempt to rehabilitate that person. Next slide, please. So in doing so, what we are aiming at? We are aiming to empower the individual and the family. And how do you achieve that? You have to achieve this thing by target the body functions and the structure. What is lacking? What the hearing is not there, I will have to restore the hearing. The lower limb has been not functioning, or absence of the part, amputated, we fit at the prosthesis. So that's the target of the functions and the structures which is lacking there. But that's not the end of the story. Just fitting the prosthesis doesn't rehabilitate a person. You have to make him participate in his life. And the participating in the life will have an environmental factor. You put a prosthesis or you put something, then you give a job at 4th floor of the building. How will he climb it? It is accessible for him. That's no point in rehabilitating him. That means accessibility has to be restored. And that's the thing. The environmental things, just now the principal Bose has mentioned that every floor of this hospital has got a physically handicapped people's friendly toilets. Yes, accessibility to the public places has law everywhere in this country. It is an advanced legislation in the country. Even to the cinema hall or to the bus station or a restaurant should have a physically handicapped people access to it. That is ramp. They cannot climb steps to put up a ramp. That sort of thing. Assisted. Wheelchair can be passed easily. That sort of thing. So this design not only restoring the part or the function, but restore the environment so that they can fully access to that and utilize the facilities. And of course, the personal factors. Again, come back to the restoring the dignity and rights of the individual. Then only rehabilitation will be successful. Next slide, please. So rehabilitation process consists of identifying the problems and the needs that the particular situation is required, then relate the problem to the modifiable and limiting factors. Something cannot be done work away. We have time to adjust to that, but what is modifiable has to be modified. Then define the target problems and target mediators, select appropriate measures. That's the role of the medical providers, the role. Then plan and implement the coordinated intervention and assess the results so that the way forward can be found out. Next slide, please. So doing so, there are problems, and the problems are many. To categorize the problem, first thing is that there's a lack of strategic planning. To lack of strategy for getting the best result, you have to have a strategy. But unfortunately, most of the countries, including ours, also lacks a proper perspective. And in that thing, there is uneven distributions of the services, the service capacity, and the infrastructure, as a democratic country, we know their infrastructure building in this thing, not a need-based, but a facility-based, or for other considerations will dictate what facility is placed to it. So that makes a lack of strategic planning in whole the approach. Taking a simple example, next slide please. This is the occupational therapies per 10,000 populations in selected countries. It said that last is in Denmark, it is about more than 10, I think 12 or yes, it will be more than 10 or almost 12 people per 10,000 population. And where is India? Not even one. And occupational therapists are the people who take care of bringing back the physically handicapped people back activities to make them fit. This is one example only. But that way, the whole needs has to be sorted out, and accordingly, the proper planning has to be done. Talking about planning and all these things, way forward. Next slide, please. Next slide. So resources, as you know, that the any government, and that way a developing country like us, the resource of the to be spent on the healthcare, this is not a priority sector, unlike defense or other communications or education, even I would say. The ratio of the expenditure to the health, the GDP ratio, is low. It has remained low so long, even after all this political noise. Still, it is low in comparison to our neighboring countries also. Leaving aside that thing, there is another problem is that many of these disabilities, I think, will increase, the magnitude will increase unless it can be intervened early, which is not there. There is no process to intervene early. It becomes complicated later. And inadequate referral system, it is non-existent in the country. In spite of all this development, we have got a very bad. So in other countries, there is a well set out referral system which cuts down the cost-wise, time-wise factor that is involved in this redressal of this difficulty. Next slide, please. So this is a common condition. So common condition, not common, uncommon, but devastating condition by person. So what is the way out? For many, we get our orthopedic surgeons, all orthopedic surgeons will know what we used to do previously. Next slide, please. We just can do a surgery, which are known as a crook and butt surgery, to make the forks and do something, the basic simple grafts, and very, very elementary thing. That's what it. But we have progressed from that, I know now, but we have come to what? Next slide, please. We have come to either giving a cosmetic part or a hook or very crude functions. But that's not the desirable function. We should be giving the thing there to the most desirable thing as it is available nowadays in the Western countries, developed countries. But here also it is available, but cost is too high. The bionic hand, almost the hand which can do all the functions of them, including the sensation. Even they can feel it. And as an orthopedic surgeon knows, the hand function depends not on the grasps, not on the power, but the sensation, the tactile sensation. So even sensation can be restored. The technology has gone beyond it. But what is it available here? Can it be made? Is it available? But can it be made available to the concerned person and the average person of this country? I think, unfortunately, it is no. Next slide, please. So the barriers are that we have to have a coordinated effort. But here we have got multiple agencies. There is a funding. Anyone working on this field will know the health used to there. Then the Department of Social Affairs come. Nowadays, even the Guwahati Medical College, speaking about Guwahati Medical, those who are associated knows, we used to have a PLFC department, peripheral limb fitting centers. That has gone down and now extinct. Then has come the CRC, Comprehensive Rehabilitation Centers. Comprehensive, not under medical college, neither in the health department, in the social welfare ministry. So completely dislocated sort of thing. Because their funding is different. Coordination is not there. So that coordination, and other things are always there, not to speak about the fund and all these things. Anyway, so problem is that there has to be strategy, there has to be lead department or ministry who will coordinate, and there is coordinate and cooperations among the concerned people these medical paramedicals, all this associated function has to be there, but it's lacking. Okay, next slide, please. I think I'm taking a little more time. Please tell me if I'm exceeding my time. Barrier or implementation, again, I will show the inaugural information and communication. Even a simple thing talking. Physically handicapped certificate, where it is given, how many medical practitioners know, where, what agency one has to approach, come to the medical college or to the hospital or go to elsewhere, something like that. People are not aware. So there is a poor communications between and across the health providers. Then there are multiple facilities. And all this that they are there, the ineffective coordination. Coordination is not there among the health service providers. Next slide, please. Another problem is their hierarchical system in the referral. Who will refer to whom and why should we refer in the civil hospital to the medical college and medical college to the other institution? All these problems are, and in the process, who suffers? Suffers that handicapped person, the physically disabled person, and this is more so in a cases like multiple disability, which is manifested in the cerebral palsy side. He will have a mental retardation. He has got a physical sort of disabilities. Then he has got the social adaptations problem, educational problem. What is the agency to take care of that? Individually, compartmental approach will not be effective for him. But where is the scope for making a concerted, coordinated effort to rehabilitate? That's the thing we should look for. Next slide, please. So all these things are there. I don't know. Next slide, please. So the families has to be involved, society has to be involved, and everybody has to cooperate and coordinate. Then only we can have something. Next slide, please. So how to go forward? How to go forward is that if we have to, as I said, that from a hook upper limb prosthesis, ordinary cosmetic prosthesis, if we have to bionic hand, amputees after that, it is costly affair. But in India, most of the people, their medical expenses are borne by out of his own pocket. And economists say that one of the causes that has kept us poor, Indian families kept us poor, is the medical expenses. It takes a lifelong savings to get cure of a serious condition in this country. So long this continues, it will be a great thing to achieve a meaningful rehabilitation program. Rehabilitation funding has to be a good investment for the human capital, because if 15% people are disabled, the 15% workforce is out of your economy. So that if we can bring back those people to the economical activities, the prosperity of the country will come. That sort of thing. That thinking has to be on that line, then only something. And the technology has to be appropriate, and it has to be cost effective. And something good does not necessarily mean is good for me. So appropriate technology has to be devised for this country, which is cost effective and beneficial to the people. Then only it will be helpful. Next slide, please. So we have to increase the human resources, and that requires training and well spread out infrastructure, and then only these facilities can be made available to the vast number of the deserving people here. Next slide, please. So expanding decentralizing services. Services are centralized in few metropolis in this country than in urban cities, but India lives in the rural hinterland. So that has to be made accessible to them, then only we can serve it. Then there have to be approach of interdisciplinary healthcare system, and if you can satisfy patients through their experience is enhanced, that will spread it, the awareness and the communication will be easy. Then accessibility and availability of the service is the key to providing the service to the needy. Next slide, please. So affordable technology has to use. Then, as I mentioned it earlier, that one example here was the amputees and the Jaipur food. Jaipur food was that it can be used in the muddy areas, climbing and all these things, and it was been accepted and appreciated all over the world. Jaipur food is not only very common in India or acceptable in India. It was a very good project supported by WHO in Cambodia, then in few countries in Africa where they have a lot of amputee, lower amputee in the mind, and these internal disturbances and all the civil wars of the Africa has caused not too much of misery, and mines was very effectively used in that thing. So resulting in lot of loss of limbs and lower limbs particularly. So Jaipur food projects was very effective. So that's the appropriateness of technologies and affordability that has to be looked into. Next slide, please. So this is a thing of very complicated upper limb processes. But if I can name so many parts are there, even if we give it, if there not the maintenance technology is available, it is an affordable. There's no point in fitting something like that. That's my point. So better we go for a ordinary thing. Next slide, please. Like that thing. Next slide. Joyful food. Yes, not good, but good enough for ordinary people. Affordable, usable, reusable, that sort of thing. So I am not advocating this, but I am stretching the point that when you go for these things, the rehabilitation program, choose a technology which is affordable and available and maintainable. These are the things one has to look into. Next slide, please. We should aim high. We should definitely think high. And we all should, ultimate objective should be empower the individual to live a full and meaningful life. Because his life and our endeavor should be helping him out to live that life. Next slide, please. So from an ordinary amputee's role of king, next. So what we have previously done the crook and bar, we should come to next step, please. They're able to play the violins and play it smooth music, then give the hope to the child. Next slide, please. We'll go to bionic hands, which can perform all the functions with the sensation even, and grow up to be a normal person and live a life. Next slide, please. And our endeavor should be that he should go out and live a full life. Thank you for your presence here. Thanks. Next slide, please. Thank you.
Thank you very much, sir, for a very nice presentation. And as rightly pointed out by sir, about the appropriate, cost-effective and technologically advanced rehabilitation, which is the need of the hour. To talk about the same, we have our next speaker with us, Professor Bhaskar Borbahain, Professor and HOD of Department of Orthopaedics and Grims, to talk on recent technology induction in rehabilitation. Bhaskar sir.
Yes. Am I audible now?
Yes, sir, you are audible, sir.
Dr. Vikas, am I audible? Okay.
Yes, sir, you are audible, sir.
Okay. Somehow unable to share my taking out. Is my laptop screen visible now? Dr. Vikas?
No, sir, it's not visible.
I think Mohan should unshare his slide.
somehow unable to share my slide to you.
Sir,
Is it
your
possible
slide is
for
being
my
shared.
folder presentation?
So you have sent the
Yeah, I
link
have
sheet,
already sent it
that is
to
being,
you.
yes, sir, that is being shared. SHUHS Assam is sharing the screen. Just it's taking some time, sir.
Okay. So I don't know how this is not coming. Maybe some technological issue.
Hello, Bhaskar.
Yes, yes.
I think Mohanto sir should answer his slide. That might be reason.
No, the Mohanto sir
Okay,
slides
no.
were also shared by SHUHS Assam only.
Vikas has shown it, no? I have not shared.
No, not me, sir. It is by SHUHS Assam only. So they are starting Bhaskar sir's slides also. Yes, sir.
I think there is somebody sharing the screen.
Sir, এইটো কৰি আছো ৰাইট এটা হৈছে হ'ব এতিয়া
What is coming? What is coming on my screen is screen sharing. Do you continue?
Because I think you can share it like me, his slides. Yes. Now we can see.
Is it visible now, sir?
Yes. We can see, Bhaskar, we can see the slides, the presentation, recent technology induction.
Okay. Now can you see?
Yeah.
Yes, sir.
Is it visible?
Yes, sir, it's visible. Yes, it's visible.
Oh,
No,
can
it's visible, sir.
Okay. So I'm sorry for the technological glitches that have just happened. At the very outset, I congratulate the Srimanta Shankardeva University of Health Sciences for taking this initiative of starting this sensitization program on disability. My topic is to talk on the recent advances. I'm thankful to my teachers who has already presented some of the points, so it will be easy for me to pass to this. If we remember 2012, you see Oscar Pistorius, who was actually in the Summer Olympics in London, and you could see that he was actually competing shoulder to shoulder with the international level athletes who are actually competing. It truly represents a fusion of humanity and technology. So this is what is the important technology that how we can help and empower and enable these people with various kind of disability. Also, Hawkins, his story teaches us why we badly need money to fight that, because we need something forward-looking solution for our well-being. So enhance the ability and achieve the extraordinary demand.
Bhaskar sir has left. I think,
Internet is problem, I think.
yeah, some internet problem issues. Okay. Sir has joined again.
Am I audible now?
So you're audible, sir, but your sound is like not clear.
Okay. Is my presentation visible?
No.
Not yet, sir. Not yet, sir.
I think Bhaskar, you should use a
Now it has come.
headphone. This will take care of your audio.
Yes, sir. Now, I hope I'm audible now.
Yes, sir, you're audible. Yes, sir. Yes.
Okay. My slides are visible, sir?
Slides are visible, sir.
Okay, fine. So we saw the story of Hawkins, where he had no voice because he was suffering from the neurological disease, the amyotrophic lateral sclerosis. And
I think again there's some internet.
Sir, your bandwidth if the location is very low.
Yeah.
because it's good to open my presentation from here, because I think there's a very unstable connection.
Yes, sorry, sir. I couldn't get you, sir.
If you can open my presentation from your end, it will be easier
Yes, sir,
for me, because I think
Yes, sir.
connection is very
Please sir, email us the presentation for university email address.
The
Because
presentation is.
Yes, sir. I have the presentation with me. I am sharing it.
Yes, yes.
Yeah, kindly share here, and I think the connection is very unstable.
yes, sir. Because লগত আছে ন বিকাশ
মোৰ লগত
হয় sir, আছে মোৰ মই share কৰি আছো।
Yes, sir.
কৰা
Is it visible?
Yeah, it is visible. It is.
Yes. Go ahead.
Slide share.
Because sir, can you see the slide?
Yes, Bhaskar sir. Bhaskar sir, are you able to?
Not yet. I'm not able to see the slides yet.
We are able to see the slides, sir.
You should change the location. If you can please change the location, sir, with the mobile.
Yeah, now I can see my slides.
Yes, sir. Please.
So, Dr. Vikas, I think you can help me with the slides, right?
Sir, yes, the slides will be there, sir. The SSUHS will be like sharing your slides, sir.
Yeah,
So,
yeah.
They will be sharing the slides, sir.
Can you pass the slides one after another? So, can I go to the next slide?
Not me.
Yeah. Okay. No problem.
Please go to the next slide. Next.
Okay.
Next. Yeah, next. So here you can see the Stephen Hawkins was unable to speak. So the WordPress technology gave Hawkins a new voice by using computer technology. By using a computer equalizer, he could click one word at a and these words are chosen from the computer screen because and the computer program finally converts this text into speech. And this is what happened until I think 1990s, end of the 90s, where he's by this time his finger muscles were also not working. So he had to use cheek muscle for this command with another technology that has come from Intel. So we can see how the technology can help people. Next. Next. Next slide, please. So if you see the problem statement, we see around 13% of the world population in the Western country are disabled, and in India it is 21 million, the official estimate. So the demand for rehabilitation service will increase as more people survive longer with substantial disability, and particularly in India, China, and US, where there's a huge number of aging population. So there will be a strong demand for provision of well-organized, coordinated, and multidisciplinary rehabilitation. Next. And as we know, that aim of rehabilitation is to maximize the participation of the patient in his or her social setting and minimize the pain and distress experienced by the patient as well as the patient party, the family, and the caregiver. Next. Next. So if you see or interestingly, the major advances in rehabilitation are rather conceptual rather than practical. And we have the old paradigm of medical management, and now the new paradigm, as rightly pointed out by earlier speaker, is psychological and the socio-cultural rehabilitation of the people, because the final goal is to integrate these persons with disability to the society. And the demand for organized and specialized rehabilitation services is required, particularly in the future, intervention that needs to be problem-oriented, evidence-based, and most importantly, the empathic, which should be human-centric. So that idea is to integrate them with the society and to make them productive. Next. So here is one small advance in the prosthesis, what Dr. Mahanta sir was saying. Here it is a directly osteo-integrated prosthesis where the prosthesis can be directly inserted into the end of the stem, and there's a piezoelectric transducer there with an elastic wave generation technique where the kind of feedback can be given so that the patient can get the right kind of gait and prevent fall and also prevent loosening of the prosthesis. So this is a huge leap in terms of the technology, a phenomenal and incredible leap as compared to older exoskeleton to endoskeleton type of prosthesis. Next. So this is for hearing handicap. We can see how cochlear implant has transformed the life of the people who cannot hear, and this is another big leap in terms of technology. Next. But when we have technology, this is a technologically feasible something, but it may not be viable, as Dr. Mahanta sir has already pointed out, because the cost factor is also there. But when we then combine the feasibility, technical feasibility, and economic viability, again, we may not have the expertise the surgeons who will do this surgery. So there's still a waiting list. So this is a very paradox that can happen when, despite having everything, we'll be unable to provide the best. Next. As orthopedic surgeon, when disability is due to arthritis, we can do joint replacement, and now we use computer navigation, infrared camera, wherein we can bring accuracy to our judgment of how much angle we can cut, because the human eye can appreciate up to 4 degrees of difference, whereas computer can go much beyond that, to 0.5 or even beyond. And probably with this computer technology, we can use a minimally invasive technique, less cut, early rehabilitation, and more accurate surgery. Next. So earlier as children, we used to see 7 wonders of the world, which are all basically hardware, all some structures. But I think in the future, one of the 8th wonder of the world will be the software, and how the human and robot interacts using an anthropomorphism or human-looking robot and artificial intelligence. I think these are the technological breakthroughs that are going to change the way we are doing rehabilitation today. Next. Next. So whether we like it or not, the future trinity of healthcare will be based basically on a combination permutation of digital technology, robotics, and artificial intelligence, because these are disruptive techniques and technologies which are going to transform the ordinary human being to extraordinary, and the disabled people and person with disability will take a great advantage from these developments. Next. So artificial intelligence, what is it? This is a technology that uses data sets, mathematical algorithmic expression to adapt to various stimulus, and that mimics human intelligence. And there is machine learning, which is a part of AI. And there will be less distinction between human and machine in the future. And there will be integration. And that is what is known as composite human being. And these are going to be, a big share will come to the rehabilitating the disabled people. Next. Next. So this is Microsoft is coming out with something AI app. This is an artificial intelligence app for blind people or people with low visual acuity, where the camera can actually point towards something and say what is there, how many people are there, whether they are right or left, what dress they are wearing. They can read a handwritten note. They can scan a barcode and say what product is there in the shop. And these are going to increase the experience of the people with disability, and they can be integrated to society in a much better way. Next. Next. So AI is basically a specially developed computer program that walk and react like human being. Next. Next. And machine learning is nothing but a subset of artificial intelligence that uses the data stored within a mathematical algorithm, a computer algorithm, to predict the trend. And this trend leads to learning, machine learning in real time by assessing and the unanalyzed data, and that to make informed decisions, just like human being takes decision on what to do and what not to do. Next. So one early variety of artificial intelligence can be that C-leg, which contains a microprocessor, a mini computer inside the hydraulic unit in the artificial knee joint. We'll go to the next slide. Next slide, where you can see the C-leg is called intelligent knee because it learns the pattern of the opposite limb because of the 50 sensors that sends continuous feedback every second to the microprocessor, and these sensors record the stress level every 0.02 second, and that is how they can walk much more efficiently, more naturally than when you put a knee which doesn't have a computer processor. Next slide. So touch bionic, as Professor Mahanta sir has already said, touch bionic is another where actually it is a limb which can be a third controlled artificial limb, where the EMG signal, just like the ECG signal that comes out from the cardiac muscle, EMG signal from the amputated limb, they can be traced and they can be decoded by the computer algorithm, and the appropriate movement can happen in the prosthetic arm by using this artificial intelligence. Next. Next. So this is here how the nerves have been transplanted to the chest muscle, and the ECG lead kind of leads are put here. And when the person imagines to move his finger, this signals can be automatically translated by the computer processor here, and the appropriate movement will happen in the actuator arm or the mechanical arm of the person, and actually it will work precisely like how we think and do something with our own hand. Next. So this is the simplified form of the same thing, where you can see the signal going to the microprocessor, and the actuator of the movement and the actuation actually takes place as desired by the person by thinking. Next. So we see the socially assistive robot. The next will be the socially assistive robot, robots for providing the mechanical assistance for walking, community-based rehabilitation by robots, and intelligent AI android, that is human-looking robots as human companion, and for people who are having chronic disability, where human intervention is done, but the 24/7 kind of assistance can be provided. Beyond going for robotic surgery, they can actually provide rehabilitation services. Although it may not be possible in a country like India now, but this is the future that's going to happen. Next. So this is one example where the robot can actually assist a person in walking like a companion. Next, please. There can be wearable robotic exoskeleton system like mechanical gait trainer, and they can actually assist. But although the evidence level is low, but these are a lot of research is happening in this area. Possibly in the future, these things will come in a big way into the market and help the persons with disability. Next. So as human, we tend to fail because of fatigue, because of your emotional lability, and because of disease and our own infirmity and injuries, etc. So next slide. So it is possible. Next slide, please. Next, please. So there is something called row bear, which can actually assist the caregiver to lift patients from one bed to another, because taking care of disabled people may be quite demanding physically for the healthcare team. So these robots can actually help transferring the patient from one to another, just like we have seen in earlier slides. Next. So there is something called now the popular area which is coming is called virtual reality rehabilitation, where the person sitting at home will have the pleasant experience of doing the exercise and other activities, like the sound coming, the music, and you can give a 3D environment where you can have a beautiful place to do exercise rather than sitting at home. So this 3D environment can make it more interesting and more engaging and more motivating. Not only that, let us go to the next slide. The computer will actually, can I go to the next slide? The computer actually keeps a record of what is happening, the progress, how much muscle is getting regenerated in terms of muscle power. All this can be calculated. So this will also need documentation. It is more fun and it is more scientific in a way. So this is virtual rehabilitation, which is probably going in a big way in the Western country. In the next future, it's going to come soon to us. Next. So the one thing that I want to discuss is the brain-machine interface, or the neuro-robotics, where it is possible to control the mechanical arm, artificial arm, by thinking, by getting the signal directly from the brain rather than from the muscle. So this can, again, based on AI and the algorithm. Next slide, where we can see in the next slide that mechanical arm controlled by thought alone is entering the human trial. The limb has a fully mobile gripper and other organs. A hair-thin microchip can be implanted either to the brain outside or directly inside, and it can be linked. Go to the next slide. Next slide, please. So this is the neurorobotic, which is combined science, robotics, and artificial intelligence. Next slide. And of course, the EMG signals and directly cortical signal from the brain. Here is an example where one amputated monkey, food is kept in front of him, and his brain is already having that the sensor from where his cortical reading can be read by the computer processor, that he wants to eat that and pick up the thing, and just by thinking, this monkey can actually eat the food which is lying in front of, using the external arm which is attached to his sensor to the brain. So this is the possibility of neurorobotics, which is going in a big way in Western country. Next. And same thing will probably extend to human being for cervical spine injury with quadriplegia. The similar thing. Next slide. Next slide, please. Next. So same thing is going for cervical spine. The same mechanism where the cortical the sensors can be put, and the similar external circuit of actuator can be used for moving the things, and it can be done possibly in very near future. Next slide. So same thing here. You can see the various EEG and the EMG pattern, which can be read by the computer and can be converted into anticipated movement outside. Next. So as our sir said, tactile sensation, very important. Touch, which is called haptics in technology, is a non-verbal critical communication. The human touch is both science and art of healing, as we know. Next. And please go to the next slide. And all kind of mathematical calculation can be done by our hand regarding texture, hardness, temperature, weight, volume, etc. These are very important sensations. So next. So all these things will be possible by using computer technology and using the humanoid robot that looks like a human being with touch. It will be possible to possibly even give tele consultation or tele treatment in terms of rehabilitation for a large number of people sitting from one side. In future, possibly that is the looks to be the future of rehabilitation. Next. I think I don't know how much time I have left, so I have, I think, few more slides, not much. So gene therapy, I just wanted to touch because gene therapy is going in a big way. You can see on your right side there are a lot of monogenic diseases like muscular dystrophy, like Duchenne's muscular dystrophy, thalassemia, and sickle cell anemia. Using an adeno-associated virus, which is non-pathogenic, already there are studies going on to treat myopathy and rare orphan diseases where they're trying to make manipulation by introducing a foreign genome where they will do a piggyback on the adenovirus, adeno-associated virus. So Glybera is already in the market against lipoprotein lipase deficiency, and with very encouraging results. So gene therapy is one technological breakthrough which is going to change a lot, particularly diseases like myopathies and neuropathies. Next. So spinal cord injury, traumatic brain injury, where actually hydrogel can be created, which can be seeded with stem cell, and the stem cell can differentiate. These are pluripotent cells. They are labile cells which can transform into whatever cells it is required by giving the right signal. Next slide. We can see here in the next slide how a neural stem cell can be created from a primary skin fibroblast. And these can be directly injected to the spinal cord for regeneration. And this outlines the procedure using a skin cell to create a neural stem cell for injection into the site of the spinal cord. So these will be the future possibilities like a guided tissue regeneration. And this is like a biomimicry where biological tissues are being created directly as a scaffold so that the Wallerian regeneration of things can happen fast. Next. So one of the last few slides is sacral neuromodulation. I think many people suffer from bowel and bladder dysfunction like neurogenic bladder where there is no control, and these can affect a lot of diseases, spinal cord injury, various neuromuscular diseases. And there can be a sacral neuromodulation where you can go for the next slide, please. Where next slide, where actually electrode can be directly put into the sacral nerve root to stimulate this bowel and bladder. And this is like a kind of a pacemaker for the cardiac pacemaker. It's a pacemaker for the bladder and bowel, and this can be worn as a belt or it can be implanted directly. So this might it's a big way for the personalized care. Medicine, personalized care and personalized medicine in terms of rehabilitation of bowel and bladder, where it is really distressing for the family and the patient and the caregiver. Next slide. So as I am ending my slides, I would just say that as a normal human being, first, when we are not disabled, what we can do ourselves to prevent disability further, particularly how to age successfully. So there's a concept called compression of morbidity, where by doing the things on the right side, that is remaining physically active, as well as mentally stimulating lifestyle. I think this is the first thing. Then comes a strong social engagement. Then comes the purpose and meaning of life. I think this is the spiritual intelligence and the social intelligence, and this beyond the EQ, the IQ. These are equally important. An environment that support this kind of lifestyle. I think this compression of morbidity means we compress all the disabilities and morbidities that happen in older age. We push them away as late as possible, so that whatever life we live in, that is very active and very productive life. So that is possible by use of technology and early intervention, early diagnosis, where there is a technological advances in terms of early diagnosis of diseases, whatever we call about molecular diagnostic or imaging modality. All those technologies are being used to early diagnose and push all this morbidity that comes with age as late as possible. Next slide. And exercise cannot be overemphasized again and again. We know all these advantages of exercise. We know that it can be done, but often we all lag behind. We are not that physically active, and that adds to a lot of morbidity and disability. I think all this can be prevented. So prevention is very important in healthy individual. And there are people who say the remaining healthy is probably the largest and the biggest service that we can give to the nation by reducing the cost of treating the people. Next slide. So how to protect ourselves by maintaining a normal weight, smoking cessation activity, physical activity, mental activity, diet. By doing this, research finds that one can postpone expected age-related disability by about 12 to 16 years. I think that's a huge advantage that can be by doing this cumulative lifetime disability risk. Next. So innovations come due to breakthrough in technology, new approaches of problem solving and thinking differently. And most importantly, empathy is most important for innovation for disabled people. Once we have empathy, we'll think what we can do to help them out. I think design thinking approach is one such approach, which is a human-centric approach with which thinks out of the box, which is known as abductive reasoning. And can I go to the next slide? And possibly to my last slide. Yeah. So as I want to conclude now, anything that technological advances that we talk about for people with disability, three factors are very important. One is desirability. That is what the patient wants, what the person really wants to improve his disability status. That is his desire, that includes a lot of empathy and understanding. Second thing is the feasibility, that is the technological feasibility, whether it is technologically possible to meet the demand of the person with disability. And viability. Viability is the economic angle, whether it is possible, is it cost effective, can you put that much of fund to do this? So what is perhaps required is a design thinking approach in service designing for people with disability, where we can combine all these three, the viability, economically viable and desirable, and whether it is technically feasible. So with this words, I'm sure I've taken a little more time. I'm sorry for that. And thank you for giving me an opportunity to Srimanta Shankardev University of Health Sciences with all the organizers. And with this, I end my talk. Thank you very much.
Thank you, Bhaskar sir, for the beautiful insight in the latest technology in rehabilitation. We have a comment from Silchar Orthopaedics SMCH that few centers in India are doing reimplantation surgery in amputee, which is naturally better than artificial one. Like you have told us a lot about recent advances in the prosthesis. Would you like to add a line or two about the recent advances in the reimplantation surgery? I know we are talking about rehabilitation right now, but since this comment has come. So, would you like to add a line or two, like because recently we are seeing more and more of reimplantation surgery. Bhaskar sir, you're there? Yes.
Yeah. Yes.
Yeah.
So I think that's a very good, very nicely highlighted from Silchar. Thank you. I think reimplantation surgery, yes, that is what we are. When I am talking about the technology here, I presume or assume that we are dealing with people who are actually having a chronic disability. So of course, yes, when we it is possible to restore the limb, and when it is possible to reimplant, of course, no artificial limb can be a replacement for an original limb. There is no two thing about it. So yes, whenever the first thing is always to restore, always to try to do the surgery. But again, reimplantation surgery, let me tell you, the availability and accessibility, these are the two important issues. And unfortunately, most of the public sector, they're not having such facilities, or these amputations can happen at any point of time. Patient will reach late, they will reach at their so available. And when they go to the private sector, the cost may be hugely prohibitive. So yes, whenever possible, when there's a team to do that, and there's the ability is there in the team, definitely that will be the first choice. There's no two thing about it, no doubt about it.
Thank you, sir. Now next, without wasting any time, we'll like to invite Professor Ranjit Barua sir, retired professor and HOD of Department of Orthopaedics, Assam Medical College and Hospital, Dibrugarh, to talk on his topic on disabilities following chronic osteomyelitis of long bone. Sir.
Yeah.
Barua, sir.
Yeah.
Yes, sir.
What happened? Share computer sound of twin screen video clip. I'm trying to share my screen, right?
Yes, sir.
I don't know whether this will work or not.
So it's loading. Yes, sir. I think the screen is shared. Sir.
Yeah. Okay. Not wasting time from my end, I'm very much thankful for the organizers for giving me this opportunity to be a part of this awareness program of World Disability Day on this 3rd December, which is being organized, which is being followed in different parts of the world. I have chosen a very simple topic, clinical topic, but although it is simple, what is happening? Why your face is coming?
The screen share has gone, like your screen is not shared anymore.
Yeah. Okay, now you can see? Can you see?
No, sir, screen is not shared right now.
We can see you, sir, but your presentation is not there.
Presentation is not seen, sir. Yes, sir. Screen is shared. The presentation is not there, but screen is shared, sir.
Okay. Now it's there. Can you see the presentation?
No, sir. Presentation is not seen, sir. White screen is shared, sir.
Oh my God. Why this is happening? You are sharing the screen. Can you see now?
So it's a blank screen only, sir.
Is there any technical moderator around?
You can see only white, right?
Yes, sir.
Okay. I don't want to see. I think you have got my slides, right?
just
হয় স্যার স্লাইড খিনি আছে স্যার কিন্তু গোটেই কমপ্লিট নহয় শেয়াৰ কৰি দিম নেকি স্যাৰ
শ্বেয়াৰ কৰি দিয়ক কমপ্লিট নহয় মানে কেলে
স্যাৰ মই যেটো পাইছো মেইলত এটো ইনকমপ্লিট স্যাৰ
Oh, you should have informed me then.
স্যার শেয়াৰ কৰি দিম নেকি
Incomplete মানে কি আছে লাষ্টৰ ফালে নাই নেকি
হয় লাষ্টৰ ফালে কেইখনমান স্লাইড নাই চাগে
Oh. I was so confident that I'll be able to share the screen with any hitch.
So I think some problem is that I was very sure I'll be visible, but I was able.
Oh, okay. Can you see? Can you see my slides?
No, sir. So it's showing that you are sharing your computer sound, sir, not.
Okay. One participant can share at a time. Multiple participants can share some advanced sharing options. I don't know.
Because share the slides. Dr. Boroy speak, no?
Okay, sir.
Yeah.
There is some. You put on the slides. Yes. We can see the slides now.
Okay. So make it as an okay. So I have chosen this clinical disability scenario, which is very important. Chronic osteomyelitis usually involves the youngsters, and if they are not being prevented, these disabilities, a long life is lying in front of them, and they will carry through with these disabilities across the whole time of their life. So this is important that we should identify what can happen to a chronically infected child and what disabilities are there, anticipated disability, and how we can go and take care of them. Next, please. Osteomyelitis, next, is an ancient disease which is present for last 250 million years. I have quoted this from some of the studies. It was first described in humans by Hippocrates. It is a progressive inflammatory process caused by pathogens, and that is bone destruction, sequestra formation, as well as soft tissue destruction. Next, please. If you look at this picture, you can see a diaphyseal osteomyelitis, chronic osteomyelitis diaphyseal sequestrum in a young child. Next, please. And if you look into this, that sequestrum is protruding through a sinus in the leg, and this is the sequestrum. It was seen in the X-ray as well clinically. This was removed during surgery. Next, please. And then this is the post-operative scenario leading to healing of the infection. Next, please. Next. The pathogenesis and end results of chronic osteomyelitis are different in children and in adults. Next, please. Most of the complications and sequelae of osteomyelitis are seen in infants and children because it is common in this age group. So we should remember This is very, very important. That is why I said in the beginning that we should check them, the perspective of these patients, in the view that they remain disabled-free in the whole life to come. Next, please. Next. Now, what are the disabilities that follows chronic osteomyelitis? There will be limb length discrepancies, there will be angular deformities, deformities due to bone loss, and pathological fractures. Next, please. If we talk about lengthening in chronic osteomyelitis, it is never more than 1 to 3 centimeter. And as you can see here, that this is the growth plate, and these are the vessels which are responsible for supply of the bone and the cartilage at this area. Next, please. And when there is an infection in the distal metaphysis or in the diaphysis, they damage the nutrient vessels. When they damage the nutrient vessels, it increases a reciprocal increase in the vascularity in the periepiphyseal area. Next, please. That leads to, next, please, stimulation of the epiphyseal cartilage. Next, please. And that leads to lengthening. Next, please. And shortening, it is more common because the infection is more near the epiphyseal plate in the metaphysis, and it can go up to 14 centimeter with an average of 8.1 centimeter. And this is because of destruction of the growth, next please, destruction of the growth plate, and occasionally due to pathological fracture which is balloonated, or there is a bone loss after sequestrectomy. Next please. What are the angular deformities? We can get a partial destruction of the growth plate, like in this case, you can see that lateral part of the growth plate has been destroyed. But in these type of cases, you can get a deformity, but range of movements is maintained. In this case, this is a genovalgum deformity one can expect in this case. Next, please. Whenever there is an infection, chronic osteomyelitis leading to septic arthritis and extension into the joint, you can get a deformity like this. But there will be bony ankylosis unlike this. And very important that the structures on the posterior side of the knee joint, neurovascular structures, are at risk. If we try to correct this angular deformity just by doing an osteotomy and try to extend it, there will be tremendous impact on the neurovascular structures. This will lead to another disability to the patient. Next, please. And if we want to do, next, please. Next. So if we want to do an osteotomy in this type of cases, corrective osteotomy, we should do it only when the infection has healed up. Now, as a clinical example, this is the girl. Next, please. So if you look at this, she had a childhood septic arthritis with ankylosis. You can look at this. If you allow this angular deformity to persist, there will be a problem in her life. She cannot walk straight. Her spine is at risk. And most important, her biological function as well as the social integration is also at stake. So we should take care of all this. We should look at into all these situations, try to prevent them. And once they form and come to us, we try to correct them in a better way. Next, please. Next. So what we did, we did a shortening at here, at this part, to correct the deformity. We did not lengthen it by doing an extension osteotomy. Next, please. And then we did a corticotomy to lengthen the limb. Next, please. Now look at this. The deformity has been corrected radiologically, clinically. Her ankle has become plantigrade. Knee is almost normal and straight, and she has got almost a 90% normal gait and other functions. Next, please. Angular deformities due to bone loss and pseudoarthrosis, formation of the pseudoarthrosis. Next, please. Now, this girl came to us who had a chronic osteomyelitis in childhood. There was a bone loss in the diaphysis of the tibia, leading to an angular deformity, hypertrophy of the fibula. But she did not have any infection radiologically and clinically. So there's a pseudoarthrosis, there's a deformity, and there's a shortening. These are the disabilities this patient has developed following chronic osteomyelitis. How we tackle this? Next, please. So to correct the deformity, we did a fibular osteotomy and chuck out of some part of the fibula. We did a corticotomy distally to regain the length. Next, please. And we did accordion maneuver at the pseudoarthrosis. And now you can see that pseudoarthrosis has healed up with correction of some of the correction. There's some persistent, maybe 10 to 15 degrees, but then this is good enough. And then there is a lengthening of the limb. Next, please. Now, when there is a shortening deformity due to bone loss following chronic osteomyelitis, what you can do? Now look at this. This is a diaphyseal sequestrum in the humerus in a child. There is a diaphyseal sequestrum in an 18-year-old girl. So for the upper limb, most of the time in children or in adult also, we always opt for a fibular bone grafting. And for the lower limb, chronic osteomyelitis with bone loss, resultant bone loss, we always prefer a technique called Elizar. Next, please. So once you want to do a fibular grafting, one very important point is that there should not be drainage for last 3 months. There should be a vascular bed at the operating site, and there should be a healthy soft tissue and blood to put the fibula in. Next, please. If you look into this, this was the case. Fibula, the diaphyseal sequestrum was removed, and then we put the fibula. It united nicely, hypertrophied, and became a normal humerus in time. Next, please. Same case, another case, fibula, you can see that hypertrophy of the fibula in this case. Next, please. Now look at this girl, 18 years female, shortened limb, severe infection. You can see signs of multiple infections and sinuses, and there is shortening. So these cases are best treated by Elizar. Next, please. And that is the X-ray. Next, please. So we did an extensive debridement. We did a corticotomy to transport the bone and lengthen the limb. Next, please. You can see in the process of bone transport. Next, please. And you can see that bone has regenerated, length has been maintained, and this is the function of the patient. Next, please. She was suffering for last almost 13 years. Next, please. Another case, next, please. You just go on showing, this is chronic osteomyelitis with pathological fracture. What you can do with this patient? Next, please. So you need to take out all the dead and infected tissues. Next, please. You may create a gap like that. Next, please. Next. Next, 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 next. So we did an Elizarov in this case. Next, please. And you can see that fracture has united. Okay. Another case of chronic osteomyelitis, a 3-year-old boy. Next, please. So we debrided, and then we put an Elizarov frame into this boy. And next, please. Look at this. The femur has reformed. We lengthened this to some extent, and then he became all right. Next, please. So Elizarov, it can eradicate infection. It has got, you can see, it is 4-pronged function. It can eradicate infection, regenerate bone and soft tissue without any plastic reconstruction. It eradicates limb length discrepancy, and it can help in returning of the functions. Next, please. Deformities due to pathological fracture. Next, please. The Campbell's, this is our standard textbook as we study in orthopedics post-graduation. Next, please. What Campbell says, causes of pathological fractures are insufficient involucrum or dense and brittle involucrum. Next, please. And it suggested a management that consists of a debridement, realignment, external immobilization with external fixation, or plaster cast if there is no shortening. Next, please. Why debridement is necessary in this type of cases? Next, please. It has been said that since it is a sequestrum is a dead bone, it's a non-living surface for attachment of the bacteria and formation of the biofilm. Next, please. And the host inability to reabsorb dead bone. That is why one should do a debridement and take out the dead bone and all the infected tissues. Next, please. And this is one of the examples. You can see chronic osteomyelitis with sequestra. So we did debridement. Next, please. We fit into it, and finally we fit into Elizarov. Next, please. And this is what the final result. Next, please. There is some restriction, but this will come up to some extent with physiotherapy. Next, please. Now, as said by Campbell, is surgical exploration is always necessary in a pathological fracture holding chronic osteomyelitis? Next, please. Next. See, there is a plethora of Indian reports which says that no surgical exploration may be needed in some of the cases. Next, please. You just align the fractures and then fix in situ. Even you don't touch the sinus tract also. Next, please. So sequestra may be partially or completely reabsorbed as a result of the host response, or may be incorporated into the involucrum. That is what these workers, they have found in their study. Next, please. So we tried this technique in one of our cases, pathological fractures overriding. We tried to correct some of the length, then we fix it in situ. We did not touch the sinus tract. Next, please. It has healed up quickly. Although it is child, and the sinus tract, which we did not touch, healed up spontaneously. So it indicates that if you give, it is a lesson from the nature that if you give rest to your infected part, it heals up reasonably. Next, please. So this is I have come to end of my talk. I have kept it little short. The carry-home message for the audience is that whenever there is a limb length discrepancy, in chronic osteomyelitis, shortening is a prominent finding than the lengthening. And if you try to equalize the limb, it should be tried after eradication of the infection. Deformities due to bone loss. In the upper limb, fibular grafting still a choice in most of the Indian centers. Especially it's a better choice in children. Next, please. Angular deformities and Elizarov. What is the rationale? It is very much helpful in angular deformities, will heal infection even with pseudoarthrosis. Even it is, as you could see in one of my femur cases, even in active infection with bone loss, this is a boon for an orthopedic surgeon. Pathological fracture in children, fixation in situ with alignment by external fixation may be sufficient in selected cases. Next, please. I think I have come to the end of my talk. This is my alma mater from where I have retired. Thank you very much for your patient hearing.
Thank you, sir. Thank you for the wonderful talk. And moving quickly to the last topic of today by Dr. Sukalyan Day, Assistant Professor of Orthopedics and my batchmate. He will be talking on congenital deformities and rehabilitation. Dr. Sukalyan.
Very good evening to everyone. Is my screen getting shared? Is it visible?
Yes.
Okay, that's great.
Yeah, it's
that's
visible.
great. So we are able now. Yes, my topic is congenital deformities and their rehabilitation. So since the beginning of my orthopedic career, I have been interested in deformity correction, children with congenital deformities, and that's why we started off. And I was very much supported by my department, and now here we are. So what we are not going to discuss today is complicated terms, complex surgical procedures, rare diseases, and details of the treatment, understanding that there might be some people who have also joined who do not belong to the medical field. So we have also omitted the surgical discussions. So basically our aim is to make a complicated and an extensive subject simple and digestible. So rather than that, we would be discussing what the prevalent misconceptions and myths are regarding congenital deformities. So we will be busting those myths one by one, and let us see what the public thinks. So congenital anomaly is a rocket science. It is very hard to comprehend. That is the myth number one. And in fact, it is fairly simple if we are willing to comprehend it. Okay, so for example, deformities can be arising from muscular system when the muscle balance, muscle strength, etc. are not quite good, and these are called myopathies, or they can also arise from the disorders of the skeletal system where the bones are not there, or they are not strong enough, or they break easily. And the third category can be from the neurological origin, where the brain or any part of the central nervous system or the peripheral nervous system might be affected, just as Stephen Hawkins was shown in Bhaskar Borgoheiser's case, where he suffered from a similar kind of disease. So apart from that, there might be some disturbance along the normal process of limb formation. The limb formation starts from a simple structure and goes towards more specific formation of the more specialized parts of the human body. So some disturbance along the normal process of limb formation might give rise to some of the deformities. Then what are those? In the upper limb, the parts may be too many, just like the polydactyly, or the digits might be too many. They might be too less. They might not be well formed, or they might be formed, but they might be joined. So this is about the upper limb. Now, about the lower limb, the limbs may remain rudimentary and they might not be that functional. Some of the bones may, though present, may be smaller. So that is called proximal femoral focal deficiency for our colleagues. And sometimes some bones may be shorter, or some bones may be entirely absent, like fibular hemimelia. So we are going to revisit these cases after a few minutes once again. Some disorders might be there where every component of the human body is present, but because of some insult to the developing brain, the tone, that is the tightness which is inherent in the muscles, get increased, or it may get disrupted. So a classical example is cerebral palsy, which is very much prevalent in our society. Sometimes the bones are okay, but they are so weak that they might be bent, or they might break at very trivial attempts at walking or lifting hands or something like that. And that is called osteogenesis imperfecta, or the brittle bone disease. We are going to go back to that child once again afterwards. Now, myth number 2 is that the treatment and rehabilitation process is always complex. For example, in order to bust this myth, we take the example of clubfoot. It is one of the commonest congenital deformities, affecting maybe 1 in 1,000 live births. Untreated clubfoot is a profound disability, and we give certificates of 65% of disability in an untreated clubfoot. But look at the treatment. In 1980s, we used to perform big surgeries, which is called posterior soft tissue release, with a fairly good result, but those results were not perfect and not satisfactory, as to say. But this person, a very famous orthopedic surgeon, Ignacio Ponseti, has developed Ponseti technique, which is based on sound principles. And the sound orthopedic principles, or medical principles, so to say, are always simple. The principles are always simple. Provided we pay attention to them, it doesn't have to be complicated. So just by going the method of serial casting, allowing the bones and soft tissue to get aligned in a natural anatomical way, we have been able to produce better results than surgery. And in 2020, we hardly find a case of posterior medial soft tissue release, which was done before. So in fact, the rehabilitation process sometimes moves from complex to simple. Now, those children who have been treated and cured of clubfoot have to be maintained in a brace, and that is the rehabilitation for the next 5 years as a part-time method. Okay, so we must be thinking that the people who make these braces must be very gifted craftsmen, because they make one of the most important Steinmeier foot abductor braces that you can see in the picture. But they are, of course, gifted. But if you see, this person has only 2 fingers. On the other limb, he has 3. So I visited their brace manufacturing center in New Delhi, and they have employed all the people who have congenital deformities. All the workers are having some kind of congenital malformation, and they are working as full-time employees, producing perfect braces for children with disabilities. So this is the epitome of vocational rehabilitation that we think are so difficult. Myth number 3. Pediatric rehabilitation is painful. No, it is not. In fact, in a child with Elizarov, we expect Elizarov is this frame which is used to distract the limbs of the congenitally deformed and shortened bones. It is not, because we expect the children to walk on the very second day of Elizarov frame fixation or any frame fixation. Even before her discharge, if encouraged, children can walk painlessly, and they do it on their own. Myth number 4, result is not dependent on the age of initiation of treatment. Some people put off the treatment because it might be treated later on, but it doesn't happen actually. This child whom we showed in the first of the slides, he doesn't have a thumb and he doesn't have a bone. So even after correcting the bone, sometimes we can make the index finger into a thumb, but it is not possible in this child of about 2.5 years because the brain has already registered that he has no thumb. So the common principle is to catch them very young. Another principle that is really rocking the whole world these days is the concept of neuroplasticity. Neuroplasticity is the availability of the brain to remodel itself. Okay, but the neuroplasticity is much more enhanced in younger children than in adults. So the principle is that the brain forms alternate pathways to circumvent a deficit, be it in the central nervous system inside the brain itself, like infantile stroke or cerebral palsy, or it might be elsewhere. But the rehabilitation has to start from the very NICU, that is neonatal intensive care unit. Only then we can reap the results of the early intervention. Number 5 myth is that people shy away from rehabilitation process because the rehab is pretty expensive. It is not, because most of the items of rehab can be made from common materials, which is presently in and around us with a very cheap expenditure. So a simple picture like this can be split and made into a puzzle, and that can constitute a very important mode of play therapy. So, and another for the economically weaker sections and poor people, we have Niramaya National Trust Scheme, ADIP scheme. All these schemes are there and which have been rolled out by the government in order to assist those people with assistive devices, rehabilitation, surgical cost, and even the travel expenses. So with a good coordination, all these things can be brought to the doorsteps of the poorest of the poor. That child with brittle bone disease, he came to us pretty late and he was not going to school till 6 years of age. But people said nothing can be done because his bones are all wavy and deformed. But after 6 surgeries and with some metallic implants, which actually the implants also grow along with the bone. So it is the marriage between the technology which Bhaskar Borgohain sir said and the sound principles of orthopedics and the regenerative capacity of the child, that this child is now able to stand on his own and is going to the school presently. Number 7 myth, the deformities will remain the same. They never do. Because without treatment, some problems are likely to worsen and the treatment is going to get more challenging. An example is the developmental dysplasia of the hip. We are lucky from orthopedic point of view because most of the things are visible and it is blatant and it is lucid, but sometimes the things can become hazy. This is something which is called developmental dysplasia of hip, where the interaction of the bones leads to the development of the normal joint. If it doesn't occur, then bone very silently comes out from the joint and the joint becomes dislocated. If he presents to us within the first 6 months of life, this brace, which is called the Pavlik harness, is all that is required. Okay, but if it comes to us in this walking child, okay, at a walking age, then the surgeries progressively go on becoming more and more difficult. So again, the story remains the same. Don't miss the first pass. And number 8 myth is that we have to live with it. What cannot be cured must be endured. But the fact is that there is always a scope for improvement. And as Mahanta sir said, the patient should be given her right to get treated, right to become better. Now, this Charcot-Marie-Tooth disease and muscle imbalance was treated with tendon transfer, then braces, and look at the confidence she has got out of it. So it is incurable. We agree with that, but it is not unmanageable. So myth number 9, these kids with normal disabilities cannot lead a normal life. Whereas the fact is that social rehabilitation in children can be brought about, and it is an important aspect of their life. They are inherently prayerful, they are social. So with proper care and patience and with proper methods, keeping in mind the environment, which is very, very important word, they can be brought to the productive part. And he is Gaurav. He is our special hero because he is riding bicycles without any ease, even without having both the limbs from forearm onwards. So a skillful movement like riding bicycle is possible for him, and he is proud of it. When I said that we would be presenting his videos, he was very happy, and his father was very happy, because that is the message he wants us to spread across. So this is the epitome of rehabilitation. He is having fun. He is using his existing limb in the perfect, best possible way, and he also knows how to get around that. His brain has already taught him how to write with his feet, and that's what he has written to his friends on the occasion of World Disability Day. So we are propelled by what we have and not by what we don't have. And now that the concepts are changing, because international classification of health disease also has international classification of function. It doesn't say international classification disability. It comes later on in time. So here we are positively trying to focus on what the person has with him. And the fun version of the children's disability is the F words. It is function, family, fitness, friends, fun, and future are the F words, which explain the international classification of function in children with disabilities. If you have time, go through it. It's a very encouraging set of information. Thank you so much. Thank you to all the organizers.
Thank you, Sukalyan, for the wonderful talk. And now we can spare a few minutes for discussion. If anyone has been any questions to the speakers, all the speakers, any of the speakers. Any questions or anything about the discussion? Yes, there's an comment from the Orthopaedics SMCS that as an awareness program, today's subjects were too much focused on locomotion only, whereas according to 2016 RPWD Act, we have 21 disabilities. Probably subject like process of certification, various schemes available, reservation facilities meant for equal participation, promotion of rights and dignity of people with disability in various aspects of life like educational, social, cultural, political, and legal could have been added. Yes, sir, very rightly said. And I think next time onwards, this topic can be included. Any other comments? Any questions? Any?
Hello.
Yes, sir.
Yeah, I am Dr. Robin Majumdar from Guwahati. Yes, I have listened to all the deliberations, starting with my friend and classmate Dr. Anil, followed by Dr. R.K. Borua, then also Dr. Sukoilan Bhaskar. All are very wonderful deliberations. I have got a very simple question to Dr. Ranjit Borua. Because during our student life, as well as when we started our career, we used to get a lot of osteomyelitis. And particularly it is common in tea garden and urban population. What is the trend now? I think there is a lot of decline in the trend and incidence of osteomyelitis now with good antibiotic and early reporting of the cases. What is your view, Dr. Borua?
Yeah, you asked for a comment on whether the incidence has gone down or not, right?
Yeah. That only.
Okay.
Because I was very much interested in managing osteomyelitis cases with my limited resources at my hospital.
For the information of the house, if you remember, Dr. Ravin Majumdar is not only a general surgeon who worked in the tea garden near Tinsukia of his whole life, but then he is a good short story writer, and he's contributed tremendously to the Assamese literature.
Thank you.
Very nice to see you, Dada. Good evening, and very nice to see you, really. So your question is whether the incidence come down. I don't think so.
Is it? Okay.
Chronic osteomyelitis is basically is seen in malnourished and poor families mostly, but it can also occur in healthy subjects as well in different predisposing factors. But if we consider the chronic osteomyelitis attending to medical college and other institutions, Dibrugarh district, I don't think the incidence has gone down because they are basically from the tea garden areas, and you have got a lot of the general health condition of the people in the tea garden areas. So I don't think so. It has gone down.
Okay.
It's almost same. It is almost same, but rather it has increased. The incidence has increased because of there is more accessibility to the hospital and also better care nowadays. Better care, as you could see in the presenting cases.
Dr. Anil, you have spent most of your time in Guwahati Medical. What is your experience? Because Guwahati Medical has got a very wider. What is your experience?
Yeah, thank you. I respectfully disagree with Dr. Burua for the incidents. I remember when I joined as assistant professor in this Guwahati Medical College, we used to see lot of osteomyelitis with diaphyseal sequestration, where the people used to land up, the child used to land up with all the complications. I think the present generation of our orthopedic surgeons have not even known the whole full diaphyseal sequestration of the femur, and not to speak of the tibia or humerus like that. One. Second impression that even for as an examiner, when you used to have osteomyelitis was a must sort of thing, must case. One has to learn it. I was an examiner at All Indian Institute of Medical Sciences. With great difficulty, I can procure a case of osteomyelitis as a case for the PG. The other examiner from Madras, he was from Madras University professor, he said, why you have to give a case of osteomyelitis? No, osteomyelitis has to be all the patients. Next time when I went as an examiner next year, again, I couldn't find a case of chronic osteomyelitis to give a PG case. This is the thing. That means the cases incidence has gone down. Why it has gone down? Two reasons. One, yes, awareness of the infection, early detection of infection, and extensive use of antibiotics. Extensive. Now osteomyelitis, whatever we get mostly because of the surgical intervention or iatrogenic. It's a compound fracture, post implants, and Ranjit will be knowing, Dr. Bora will be knowing, even we had a airway infections seminar. I have to present that iatrogenic infection, that means implants and the infection sort of. Now, osteomyelitis, cause of osteomyelitis is more of a surgical intervention, iatrogenic, caused by the surgeon, not of hematologicals. Not of, can you hear me? I think there is disconnection.
Yeah. You are audible.
Okay. So it is hematogenic osteomyelitis because of the non-wound and osteomyelitis nowadays is mostly because of the trauma and surgical intervention. And pure simple the classical case of hematogenous osteomyelitis, incidence is going down.
I think can I just differ with Professor Mahanta? The scenario in Guwahati may be different because you do not have much of tea gardens around, and what we get in Dibrugarh, but in my entire career, I have not seen that the infection has gone down. I mean, the true osteomyelitis, incidence of true osteomyelitis has gone down in our attendance in a medical college in MC. This is because of so many factors I have told you, poor nutrition, and then people are they come late. They have got so many children in the family. They don't give a damn if something going on in one of the kids. So delay in presentation, I think we get in Dibrugarh.
Yes, if I am permitted, I am for the orthopedic surgeons only. I will statements rather. If orthopedic surgeons only, the other will not enjoy it. If you read Campbell's textbook of orthopedics, the treatment and complications of diseases, one of the complications of the fracture tibia was non-union. And non-union was because that, yes, non-union because of, then causes, we used to give the causes of non-union immobilization, this thing. Then when it started treating it, then subsequent editions came down that yes, non-union has gone down, incidence of non-union has gone down. Then the non-union incidences again has come up, subsequent editions. I am talking the following all this. And this time the non-union cause was surgical intervention. When people just surgeons started, well, because they again gone back to conservative treatment, that sort of thing. My impression is that hematogenous osteomyelitis is going down and iatrogenic osteomyelitis is coming up. That's the impression that I could get. Anyway, in Guwahati, at least in the urban areas, my practice and my experience shows that yes, might be disease. Anyway, this is Bianca. I think other people will not enjoy this discussion. Thank you.
Dr. Anil and Dr. Borua, incidentally, I got one at Marori Hospital about 5 years back. A young boy of about 8 years old, he came with an abscess, first cellulitis and abscess of the lower end of lower third of his leg. Then it developed into abscess. I drained it, but I had this mind in this acute osteomyelitis. I have been doing serial X-ray from time to time, but still then it was not detected. He went home, and after about 1 week, he came with severe pain and swelling of entire left, the affected leg. I got the X-ray done, and I saw this this initial phase of osteomyelitis. What do you call? I just forgot that term. It is a case of well-established osteomyelitis. So I think I missed somewhere. Then I had to refer to one of the orthopedician at Guwahati. So that is the last case I have seen about 5 to 6 years back. It is really very less in Guwahati. It is as Dr. Anil has pointed out, because we have got 2 orthopedician previously, now 1, but hardly they get any case. So it is prevalent in actually Upper Assam, particularly in tea garden area, mostly actually. During my tenure there for 26.5 years, I used to get number of cases actually. Still I remember. And even I made a small series, if I remember, for presentations after. Okay, thank you.
Thank you.
Any other questions? I think if there are no other questions, we are coming to the end of our program. So I'd like to end the program with concluding with a vote of thanks. Firstly, to our patron, Professor Deepika Deka ma'am, though she could not be present here today. I'd also like to thank Professor Isi Bashir sir, our chief guest, all the speakers, and all the executive members, including our DME sir, the principal of all the medical colleges, President IMA, Dr. Satyajit Bra sir, President Teacher Association, Dr. Jayanta Chaudhary sir, Dr. Sudhir Bodhan sir, and all our respected audience. And in the end, I would like to apologize for if I've left out any names and for any mistake in the conducting of this program. So thank you very much.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you.
Good night.